Welcome to our channel. In today's LFT Decoder Series, we are mastering one of the most important concepts in hepatology, the R ratio. If you have ever been confused about whether an abnormal liver function test represents hepatocellular injury or obstructive cholestasis, this single formula will make your diagnosis much easier. The R ratio is a simple yet powerful tool that compares the elevation of alanine aminotransferase ALT and alkaline phosphatase ALP relative to their upper limits of normal. In just a few seconds, it helps classify the pattern of liver injury into hepatocellular, cholestatic, or mixed. This concept is valuable in daily clinical practice. By the end of this masterclass, you will exactly know how to calculate the ratio, interpret every result, and avoid common diagnostic mistakes and confidently approach any liver function test question. Let's begin and decode liver function test like a hepatologist. Let's begin with a real clinical scenario. Meet Mr. Ramesh Patil, a 52-year-old businessman from Pune who presents with yellowing of the eyes for the past 5 days. His history is highly suggestive of obstructive jaundice. He reports painless progressive jaundice, clay colored stools, dark urine, and generalized itching, especially at night. Importantly, he has no fever, no abdominal pain, or no rigors, no history of alcohol use, and no recent medications. Now let's examine his liver function test. His total bilirubin is 8.2 milligrams per deciliter, with direct bilirubin 6.5 milligrams per deciliter, indicating predominantly conjugated hyperbilirubinemia. AST is 65 units per liter, ALT is 70 units per liter, showing only mild deviation and elevation. However, alkaline phosphatase is markedly elevated at 420 units per liter, and GGT is also significantly raised at 280 units per liter. His INR is normal, suggesting preserved liver synthetic function. So, here is the question. Does this represent hepatocellular injury, cholestatic obstruction, or a mixed pattern? Instead of guessing, in the next we will calculate the R ratio, that most reliable way to classify the pattern of liver injury in seconds. Before calculating the R ratio, let's discuss one of the biggest mistakes every clinicians make, trying to interpret liver function tests by simply looking at the numbers. The first mistake is treating bilirubin as the diagnosis. Bilirubin tells you that the jaundice is present, but it does not tell you why it is happening. Both hepatocellular injury and biliary obstruction can produce high bilirubin levels. The second mistake is ignoring the relationship between the ALT and ALP. Looking at AST, ALT, ALP, and GGT separately often leads to confusion. Instead, we need to compare them using objective formula to identify the dominant pattern of the liver injury. The third mistake is jumping directly to viral hepatitis workup. In countries like India, viral hepatitis is common, but if the biochemical pattern actually suggests biliary obstruction, delaying imaging such as ultrasound, MRCP, or ERCP may postpone the correct diagnosis and treatment. Finally, never assume every jaundiced patient taking anti TB therapy has drug induced hepatitis. Always evaluate the liver enzyme pattern first because gallstones, biliary obstruction, and even malignancy may coexist. So, don't eyeball liver function tests. Calculate the pattern objectively before deciding the next investigation. In the next slide, we will learn the R ratio formula that makes this process quick, accurate, and exam friendly. Now, let's learn the single formula that transforms the liver function test interpretation, the R ratio. The R ratio objectively tells us whether the liver injury is hepatocellular, cholestatic, or mixed. The formula is simple. R equals ALT divided by its upper limit of the normal divided by the ALP divided by its upper limit of the normal. Let's apply it to the Mr. Patil's case. His ALT is 70 units per liter. Assuming the laboratory upper limit of normal is 40, we calculate 70 divided by 40, which equals to 1.75. Next, his ALP is 420 units per liter with an upper limit of normal of 120. We calculate 420 divided by 120, which equals to 3.5. Now divide the two values. R equals 1.75 divided by 3.5, giving the R ratio of 0.5. How do we interpret it? If the R ratio is less than or equal to 2, the pattern is cholestatic or obstructive. If R ratio is between 2 and 5, it represents a mixed pattern. If R ratio is greater than 5, it indicates hepatocellular injury. Since Mr. Patel's R ratio is zero point 0.5, this is clearly a cholestatic pattern, making biliary obstruction far more likely than the primary liver cell injury. This one calculation eliminates guesswork and guides the next investigation with confidence. In the next slide, we will see how R ratio changes your clinical decision making in the real world practice. Now, let's bring everything together. After calculating the R ratio, Mr. Patel's value is zero point 0.5, which clearly confirms a cholestatic pattern of liver injury. This changes our entire clinical approach. At this stage, the priority is not viral hepatitis testing. Ordering hepatitis serology first may delay the diagnosis if the patient actually has biliary obstruction. Instead, the correct next step is an urgent abdominal ultrasound to look for dilated bile ducts, gallstones, biliary strictures, or a pancreatic or biliary mass. Depending on the findings, further evaluation with MRCP, CT scan, endoscopic ultrasound, or ERCP may be required. This is why the R ratio is so valuable. It does not just classify the liver injury, it guides the next investigation and helps avoid unnecessary tests while speeding up the correct diagnosis. Remember this clinical poll. High bilirubin alone does not tell you the cause. The R ratio tells you the pattern, and the pattern determines the next step. To truly understand the liver function test, you need to understand why these enzymes increase in the first place. These are two completely different mechanisms of the liver injury and each produces a unique laboratory pattern. First, let's look at the hepatocellular injury. Here, the liver cells themselves, called the hepatocytes, are damaged by the conditions such as the viral hepatitis, drug induced liver injury, autoimmune hepatitis, or ischemia. When the hepatocyte membrane is disrupted, the enzymes stored inside the cells, mainly ALT and AST, leak directly into the bloodstream. As a result, ALT and AST rise dramatically, often much more than the ALP. This produces a hepatocellular pattern of the liver injury. Now compare with cholestatic or obstructive injury. In this situation, the hepatocytes are not the primary problem. Instead, bile flow is blocked due to gallstones, biliary strictures, tumors, or intrahepatic cholestasis. The pressure inside the bile ducts increases, stimulating the production and release of the ALP and GGT, which are concentrated in the bile duct lining. Because bile cannot drain normally, conjugated bilirubin also accumulates, producing the jaundice. So, the dominant laboratory picture is high ALP, high GGT, and elevated direct bilirubin, while AST and ALT are only mildly elevated. This is exactly what we observed in Mr. Patel's case. His enzyme pattern reflects biliary obstruction, not widespread destruction of the liver cells. Understanding these mechanisms makes liver function test logical instead of something you simply memorize. Now that you know how to calculate the R ratio, let's understand what each range actually means in the clinical practice. Think of R ratio as a spectrum with three distinct patterns. If R ratio is less than 2 or 2, the injury is cholestatic. This means the bile flow is impaired. Common causes include common bile duct stones, malignant biliary obstruction such as the pancreatic or cholangiocarcinoma, primary biliary cholangitis, primary sclerosing cholangitis, and drug-induced cholestasis. These patients usually need biliary imaging, not an extensive hepatitis workup. If the R ratio is between 2 and 5, it represents a mixed pattern where both hepatocellular injury and cholestasis are present. Common causes include the mixed drug induced liver injury, flares of chronic viral hepatitis, infiltrative liver diseases, and sepsis related liver dysfunction. These causes often require a broader diagnostic evaluation. Finally, if the R ratio is 5 or greater, the pattern is hepatocellular. Here, the primary injury is to the liver cells themselves. Typical causes include viral hepatitis A, B, C, or E, drug induced liver injury such as anti TB therapy or paracetamol toxicity, autoimmune hepatitis, and ischemic hepatitis. In these patients, viral serology, autoimmune markers, and medication history become especially important. So, here's an easy way to remember it for exams and clinical practice. R less than or equal to 2, think bile ducts. R between 2 and 5, think mixed injury. R greater than or equal to 5, think hepatocytes. Once you know the R ratio, you are no longer guessing. You are confidently narrow the differential diagnosis and choose the appropriate next investigation. Once you have calculated the R ratio, the next step becomes much more straightforward because the pattern tells you which investigation to order. If the R ratio is 5 or greater, the injury is hepatocellular. Your focus should be on identifying the diseases that directly damage the liver cells. Begin with viral serology, including the hepatitis B surface antigen, anti hepatitis C antibody, and IgM antibodies for hepatitis A and hepatitis E, depending on the clinical setting. If the viral tests are negative or autoimmune disease is suspected, proceed with an autoimmune liver panel, including anti nuclear antibody, anti smooth muscle antibody, and serum IgG levels. On the other hand, if the R ratio is 2 or less, the pattern is cholestatic. Here, first line investigation is an abdominal ultrasound. It is quick, inexpensive, and highly effective for detecting bile duct dilation, gallstones, or masses causing the obstruction. If the ultrasound confirms biliary obstruction or shows dilated ducts, the next step is MRCP for detailed biliary imaging or ERCP, which can both diagnose and treat certain obstructive lesions. Regardless of the R ratio, there are two investigations you should assess in every patient with jaundice. First, GGT helps confirm that an elevated ALP is coming from the liver rather than bone. Second, always check INR and serum bilirubin as these are the best indicators of the liver's synthetic function and helps assess the disease severity. Don't order every test for every patient. Calculate the R ratio first, then let the injury pattern guide your investigation. This approach saves time, reduces unnecessary testing, and leads to faster, more accurate diagnosis. Now let's bring everything together with one high yield comparison that every medical student should remember. When differentiating hepatocellular injury from cholestatic or obstructive injury, compare the entire laboratory pattern, not just a single value. In hepatocellular injury, the dominant abnormality is a marked rise in AST and ALT, often more than 10 times the upper limit of the normal, while ALP and GGT are either normal or only mildly elevated. The R ratio is 5 or greater, indicating that the liver cell injury is the primary process. Bilirubin may be elevated, but it can either be conjugated or unconjugated depending on the underlying disease. Acute imaging is usually not the first priority unless the obstruction is clinically suspected. Classic examples include viral hepatitis, drug induced liver injury, and autoimmune hepatitis. In contrast, cholestatic or obstructive injury is characterized by a marked elevation of ALP and GGT, often more than 3 times the upper limit of the normal. AST and ALT are only mildly increased. The R ratio is 2 or less, confirming a cholestatic pattern. Here, bilirubin is predominantly direct or conjugated because bile flow is impaired. The first imaging test should always be an abdominal ultrasound to identify the bile duct dilation, gallstones, or obstructing masses. Common causes include common bile duct stones, malignant biliary obstruction, and primary biliary disorders. Here's a quick exam question. A patient has an ALT of 200 with an upper limit of normal 40 and ALP of 100. which is also the upper limit of the normal. The R ratio is 5, indicating the hepatocellular pattern. So, AST and ALT point towards the hepatocellular injury. ALP and GGT point towards the cholestasis, and R ratio objectively confirms the diagnosis. Now let's focus on another high yield liver function test concept frequently asked. The D-Ritis ratio, also known as the AST to ALT ratio. Here's a clinical scenario. A 38-year-old chronic alcoholic patient presents with jaundice. His AST is 180 and ALT is 60. What is the most likely diagnosis? Let's calculate the ratio AST by ALT. 180 divided by 60 equals to 3. An AST to ALT ratio greater than 2 is highly suggestive of alcoholic hepatitis, making option B the correct answer. But why does this happen? These are the two important reasons. First, alcohol causes mitochondrial injury, releasing large amounts of AST because AST is present in both cytoplasm and mitochondria of the hepatocytes. Second, chronic alcohol use leads to vitamin B6, which reduces the ALT synthesis more than AST, further increasing the ratio. Now, remember this quick exam guide. If AST to ALT ratio is less than 1, think of acute viral hepatitis, where ALT is usually higher than the AST. A ratio between 1 and 2 is commonly seen in NAFLD, NASH, and many chronic liver diseases. A ratio greater than 2 strongly points towards the alcoholic hepatitis, although it may be also seen in advanced cirrhosis and occasionally Wilson's disease. One important point: never diagnose liver disease using AST to ALT ratio alone. Always interpret it together with the patient's history, bilirubin, ALP, GGT, and R ratio to identify the underlying pattern of the liver injury. AST is always greater than ALT by more than twofold. Think alcohol until proven otherwise. Before we finish this topic, it is important to know not every patient should wait for an R ratio calculation. Some clinical situations are true emergencies where immediate actions takes priority. The first red flag is Charcot strain, fever, right upper quadrant pain, and jaundice. This combination strongly suggests ascending cholangitis, a life-threatening infection of the biliary tract. These patients require urgent IV antibiotics and emergency ERCP for biliary drainage. Never delay treatment while completing the additional laboratory calculations. The second red flag is the hepatic encephalopathy with coagulopathy. If a patient develops altered mental status along with a rising INR, think of acute liver failure. This is an ICU level emergency requiring immediate stabilization, intensive monitoring, and urgent referral to a liver transplant center if indicated. The third warning sign is Corvaisser's sign, a painless, enlarged, palpable gallbladder associated with jaundice. Unlike gallstones, these findings strongly suggest a malignant biliary obstruction, such as carcinoma of the pancreatic head or cholangiocarcinoma. These patients require urgent imaging and specialized evaluation. Finally, remember that a rising INR despite normal bilirubin should never be ignored. The liver synthetic function can deteriorate before jaundice becomes apparent. An increasing INR may be the earliest sign of liver dysfunction, so monitor these patients closely and involve a hepatologist newly. The take home message is simple: clinical red flags always override laboratory algorithms. If you identify one of these emergencies, stabilize the patient and initiate urgent management first. The R ratio is a valuable diagnostic tool, but it should never delay life saving treatment. Let's complete the case and see how the systematic approach led to the correct diagnosis and the treatment. On day 1, we calculated the R ratio, which was zero point 0.5. This confirmed a cholestatic pattern of the liver injury. Instead of ordering viral hepatitis test first, An urgent abdominal ultrasound was performed because obstruction was strongly suspected. Later that evening, the ultrasound revealed a dilated common bile duct measuring 12 millimeters along a hypoechoic shadow in the distal common bile duct. These findings strongly suggested choledocholithiasis, or a common bile duct stone. On day 2, an MRCP was performed for further evaluation. It confirmed a 9 millimeter common bile duct stone with no evidence of pancreatic or biliary mass. At this point, the gastroenterology and hepatobiliary surgery teams were consulted to plan the definitive treatment. On day 3, the patient underwent ERCP with sphincterectomy. The obstructing stone was successfully removed without any complications, restoring normal bile flow. Over the next 2 weeks, the patient's recovery was excellent. His bilirubin decreased to 1.1 milligram per deciliter and pruritus completely resolved, and his stool color returned to normal, confirming resolution of the obstruction. He was discharged with follow-up advice and counseling regarding the prevention of the recurrent gallstones. This case highlights the importance of using the R ratio as an objective decision-making tool. By correctly identifying a cholestatic pattern, unnecessary viral workup was avoided. Appropriate imaging was performed early, and the patient received timely ERCP before complications developed. So, the clinical lesson from this was calculate the pattern, order the right investigation, and treat the underlying cause, not just the laboratory values. Let's conclude with some practical clinical pearls that are especially relevant for medical practice. The first is ADT induced hepatotoxicity. The first line anti TB drugs, isoniazid, rifampicin, and pyrazinamide, can all cause drug induced liver injury. Before starting ADT, always obtain baseline liver function test. If the patient develops symptoms of the hepatitis with ALT more than 3 times the upper limit of normal or remains asymptomatic but the ALT rises above 5 times the upper limit, stop the hepatotoxic drugs and investigate further. Once the liver function normalizes, reintroduce the medications one at a time under close monitoring. The second pearl is monsoon viral hepatitis. During the rainy season, outbreaks of hepatitis A and hepatitis E increase because of the contaminated food and water. Hepatitis E deserves special attention as it is a major cause of acute liver failure in pregnancy. In patients with hepatocellular pattern of liver injury, especially during the monsoon months, consider testing for IgM anti-HAV and IgM anti-HEV, while also emphasizing safe drinking water and hygiene during the patient counseling. The third point is a cost effective diagnostic approach, which is highly relevant in resource limited settings. For patients with cholestatic pattern, abdominal ultrasound should always be the first imaging investigation. It is inexpensive, widely available, and can quickly detect the bile duct dilation, gallstones, or masses. Reserve MRCP for patients with positive or inconvulsive ultrasound findings. If the advanced procedures such as ERCP are not available locally, refer the patient early to a tertiary care center to avoid delays in the treatment. Always remember, the good clinical practice is not only about knowing the diagnosis, it is also about choosing investigations that are appropriate, affordable, and accessible for all the patients. Combining evidence-based medicines with practical decision making leads to better outcomes in everyday clinical practice. Let's summarize the most important lesson from this masterclass. When you encounter abnormal liver function tests, don't rely on guesswork or isolated laboratory values. Instead, calculate the R ratio first. A R ratio of 2 or less indicates a cholestatic or obstructive pattern where your next step is abdominal ultrasound followed by MRCP or ERCP if indicated. A ratio of 5 or greater indicates hepatocellular pattern where the evaluation should focus on viral hepatitis, drug-induced liver injury, autoimmune hepatitis and other causes of hepatocyte damage. Remember, the R ratio transforms confusing liver function test into a clear diagnostic pathway. It helps you choose the right investigation, avoid unnecessary tests, and reach the diagnosis faster. Most importantly, never let laboratory calculations delay emergency management. If the patient has red flags such as ascending cholangitis, acute liver failure, or malignant biliary obstructions, stabilize the patient and treat immediately. One ratio, two patterns, zero confusion. Thank you so much for watching this masterclass on the LFT Decoder Series, the R ratio masterclass. I hope the session helped you understand how to objectively differentiate hepatocellular and cholestatic liver injury using a simple evidence based approach. Remember, don't memorize isolated liver function tests. Understand the pattern, calculate the R ratio, and let the results guide your next investigation. This one calculation can save valuable time, prevent unnecessary tests, and improve patient care. If you found this video useful, please like, share, and subscribe our channel. Also, share it with your classmates, colleagues, and fellow healthcare professionals. Your support motivates me to create more and more high yield medical content. If you have any questions or want me to cover a specific medical topic, leave it in the comments below. I read every comment and love hearing your suggestions. Thank you once again for being a part of our family. Medicine that sticks, learning that lasts. So, see you in the next video.